vesicles and the urethral part. In the sagittal section, this is in the coronal section. You can see there are two muscular tubular structures, corpora cavernosa, and a supportive structure, corpus spongiosum. These are smooth muscles, basically. Are there any structural problems? Definitely yes. Majority of our patients complain that they are losing the length. Why is that? I mean, first thing is aging. As you can see, aging affects every structure, mainly tunical degeneration. It affects corporal smooth muscles and also arterial system. So arteries get thickened. Added to that, if there is diabetes, there is extremely increased risk of corporal fibrosis for various reasons. And if we add on secondary hypogonadism due to diabetes, it gets much worse. Can you do anything about it? We can't prevent aging. Of course, we can control diabetes. Probably that's the mainstay. Nothing has been proven so far to increase or maintain the penile structure. Other structural problems, Peyronie's disease. I'm sure you all know about Peyronie's disease due to a fibrous plaque which causes bending of the penis. It causes curvature. And severe curvature, greater than 60, the penetrative sex is almost impossible. Anything in diabetics? As you can see, the chronic phase, there are two phases in Peyronie's disease. Peyronie's disease, although etiology is uncertain, it is due to microvascular trauma and then the fibrous formation. So the latter is the chronic phase, and you can see in diabetes, the chronic phase of that is significantly high. And you can also see the severity is much, much higher. We are justified referring to urologists at this stage. Ejaculatory problems, are they common? Yes. I mean, people can't distinguish between erectile dysfunction and premature ejaculation. They almost go synonymous for lots of people, not only patients, even for doctors. Ejaculation has got various levels of regulatory mechanisms. Brain, it's a neurotransmitter, serotonin delays, dopamine shortens. Thoracolumbar plexus, that has a role. It's a sympathetic thing that initiates the process of ejaculation, and the completion, the later half of ejaculation, is through the parasympathetic sacral outflow. Premature ejaculation is extremely common in diabetics, especially Asian origin. We don't know why. It's defined as intravaginal ejaculatory latency time of less than 3 minutes. But in our practice, it is usually people complain of less than 1 minute. Lifelong PE is mainly psychological. It's got a neurobiological explanation, but acquired PE is due to any causes which affects the male system. Diabetes is estimated, in diabetes it is estimated to be about 40%. It could be more. I'll skip that. Therapy is, of course, psychosexual therapy, and if we come to pharmacotherapy, there are SSRIs. Recently we got Depoxetine, which is on-demand SSRI, which is like PD5, so they have to take about an hour before sexual intercourse. Local anesthetics, it reduces the sensitivity, but unfortunately the partners experience numbness, so that's not great. Delayed ejaculation, anejaculation, retrograde ejaculation, they're all extremely common in diabetics, and especially if they develop autonomic neuropathy. Delayed ejaculation is usually greater than 30 minutes. Some people may have prolonged intercourse which may last more than 45 minutes. There are some drugs which can cause this, SSRIs, as we discussed just now, and alpha blockers as well. The treatment for that is sympathomimetic agents like ephedrine, pseudoephedrine. We got to be very careful here because of hypertension and ischemic heart disease, which can coexist in diabetics. What about urinary tract symptoms? Recently, prostate problems have been shown to be strongly associated with metabolic syndrome and diabetes. Again, we can explain that through nitrinergic system and also through increased sympathetic tone. And it can cause infections, especially in diabetics. Prostatitis, very common, chronic prostatitis especially. So if we can find out the cause of infection, then antibiotics, so a prolonged course of antibiotics as per sensitivity. And of course, we shouldn't forget other management aspects of this. Now coming to the big problem, erectile dysfunction. So penile erection, again, a regulatory mechanism is at various levels: central nervous system, olfactory stimuli, visual stimuli, etc. And then the peripheral system. Again, sympathetic in the thoracolumbar and parasympathetic in the sacral. In simplistic terms, blood should flow in, the erectile tissue should expand, and venous return should be cut off. That is the whole process there. There are several phases of erections. I'll not go through this in detail. But these are important. Psychogenic, which are more common in adolescents and early young adults and adolescents. Reflexogenic, which is due to tactile stimulation that dominates during mature years. Nocturnal erections are non-sexual erections. So that's psychogenic erections are related. It starts in early adolescence and persists lifelong. It's usually not noticed by men. Most men are awake when they wake up in the morning. It occurs, it coincides with the REM sleep. But as in the aging process, sleep is disturbed and it's not that tightly coupled with REM. So that's what you can see here, the tumescence occurring with REM sleep. Lots of neurotransmitters play a role in erections, oxytocin and dopamine, for example. And of course, you know about the peripheral system. Mechanism, I'd like to spend a few seconds on this because this is important, because there are lots of future implications. There are two major pathways. One is the nitrinergic pathway, increased nitric oxide, increase in cyclic GMP. That is what our phosphodiesterase inhibitors do. The other one is a prostaglandin pathway. That increases cyclic AMP. So this is synthetic prostaglandins we have got now, like Cavachect, Muse, and things like that. Nitric oxide, we know it increases cyclic GMP. It has got protective function on the endothelium, and deficiency causes endothelial dysfunction. Now, detumescence, contraction, loss of erection is caused again by two pathways. One is the endothelin phospholipase pathway. The other one, which is interesting, is the Rho kinase pathway. As you can see, the Rho kinase pathway here, you can see that receptor. And the second thing, it's angiotensin 2 stimulates that receptor. So if the angiotensin 2 is high, people can have erectile dysfunction, and that is where sartans or ARBs have been shown to help erectile dysfunction by reducing the detumescence phase. And recently, Rho kinase inhibitors are in development, and those probably will become the next Viagra, next big thing after Viagra in near future. So erectile function is a fine balance between various agonists and antagonists. Is there a role of testosterone? Yes, testosterone again potentiates two different pathways. It has been shown one is the Rho kinase, which helps in the detumescence. Other one is it promotes nitric oxide donation for the cyclic GMP pathway. So male sexual activity is a very well orchestrated phenomena involving nervous system, vascular system, hormonal system, and the musculature. Any hit to any of these can cause erectile dysfunction. It is such a fragile thing. So any problems to any of these factors can cause erectile dysfunction. It is persistent inability to attain and maintain. In diabetics, it can be a marker of occult cardiovascular disease, and whatever the cause is, it will have an effect on the mood and on the confidence level and on the psychological aspects of sexual function. Quickly look through epidemiology. Massachusetts male aging study is the largest epidemiological study, showed that ED increases with age. Severity of ED increases with age as well. It is significantly associated with other comorbid conditions, especially diabetes, where there's 56%, and complete ED is 28%. It shares the common risk factors: hypertension, hyperlipidemia, diabetes, and depression. Again, comorbidities are very common in men with ED. High prevalence of ED in comorbid conditions. If you look at diabetes, that is the top cause for erectile dysfunction. And if there are other problems, it can compound the problem. Metabolic syndrome, again, it correlates very well with the individual components. As the components of metabolic syndrome increases, the erectile dysfunction increases. Diabetes and erectile dysfunction, Fred Wu, my another mentor, of course the greatest mentor is sitting here. Fred Wu has, in his earlier stage, has shown that a survey of 540 men, he looked at the correlation between various aspects of diabetes and erectile dysfunction. And he showed that longer the duration of diabetes, worse the control, microvascular, pre-existing microvascular complications, they all contribute to ED, and the prevalence of ED is significantly higher in these group. Thyroid dysfunction again causes that, acromegaly can cause. Psychological issues, psychological causes of erectile dysfunction, and medical causes, organic causes of vasculogenic, neurogenic, endocrine, drug-induced, or mixed. That is the most common sort of situation we come across. Plenty of causes. Of course, diabetes ranks number one, almost. How do you differentiate between psychogenic and organic? Organic is more gradual onset and lack of morning erections. That is a key thing in organic. Lots of issues causing this psychogenic erectile dysfunction. Organic, again, as we discussed, structural changes, functional changes, risk factors, comorbidities, they all cause, and of course, when the structure shrinks, venous venous drainage is compromised, so there is early detumescence. So lots of factors playing a role here. Testosterone, yes, it is playing a role. I mean, as you can see, greater the BMI, lower the testosterone, both total and free, despite increase in SHBG. So how does fat cause low testosterone? Lots of mechanisms which have been discussed. Sorry. Fat in men, there's aromatase which converts testosterone to estrogen, and estrogen feeds back negatively and reduces the LH-FSH. So what we find in diabetes and metabolic syndrome is a secondary hypogonadism. So it's normal, low T and inappropriately normal FSH-LH. So there is leptin which can act directly, and mostly adipocytokines, kispeptins, which can reduce GnRH. It's multifactorial, as you can see, pathogenesis in metabolic syndrome and diabetes. It can be due to all possible causes: psychological, vascular, neural, hormonal, and it often coexists, and it often is multifactorial. If it's added on to hypertension, again, problem gets worse due to this mechanism, reduction in elasticity and vasoconstriction. Smoking definitely causes diabetes due to increase in oxidative stress. Atherosclerosis, again, compromises vascular inflow. And as you can see, this is the tiniest artery, and it can be a marker of occult cardiovascular disease before the disease starts anywhere else in coronary artery or other arteries, major arteries. This is likely to be compromised first. If they are abusing alcohol, various reasons why alcohol causes erectile dysfunction. If there is sleep apnea, poor sleep hygiene, that again compromises on the nocturnal erections. Of course, the top picture is presumed to be non-sexual erection. Endocrine causes, various of them, including prolactinoma, which is main thyrotoxicosis and hypothyroidism. Lots of drugs are associated with it. How should we evaluate? A detailed history, and in particular IIEF questionnaire that will be able to tell us about the severity of ED. Psychological issues we should be considering. Examination should be thorough, looking for peripheral vascular disease, looking for signs of hypogonadism and other coexisting endocrine problems. Penile assessment carefully for any scars, testicular examination, and prostate. Investigations, when whoever complains of erectile dysfunction, we are bound to check their testosterone.